Test, test. Morning, Zach. Feeling all right?
Yeah, doing good.
Good. In my night class, I have 10 people on quarantine.
Oh, wow.
Yeah, I sometimes have more people on the screen than I do in the classroom.
Yeah, that'd be weird. I should be
Yeah.
back. I'll be back on Wednesday, though. We get out Tuesday.
Discouraging to some extent, isn't it?
Yeah, definitely.
You can either turn in a hard copy or email them to me, either one. I'm easy. Zach, the question was asked about the vocabulary sheet. You can turn in a hard copy or an electronic copy. It doesn't matter to me.
Okay. Perfect.
If you do turn in electronic copy, put your name in the header, because electronic copies all look the same. Just put your name in the header, that way I know it's yours. So you don't have one that says Cougars Huffle?
We have like the one to pull up, but it doesn't stay up well on my face.
Yeah, and the Gators don't give you much protection.
No, not really.
CDC's tested those.
You can tell because it's really easy.
Well, even 2-ply, the protection is poor. It's just not good. So those are not recommended. Chapman, way back there. Hey, Chapman. $90 bananas. Oh, it's go. It does. Looks like a 90. Okay.
I mean, if you ate 90 bananas, you'd have to go. You know what I'm saying?
Either that or you'd be pretty plugged up. Nah. Yeah. The hyperkalemic.
Have you ever had like a banana and then carbonated? That's a bad thing. A real bad thing.
Banana, then
Banana and carbonated beverage will like
yes,
will literally
I have done that.
I have no clue why.
I'm not sure why either, but it's pretty foul. I thought at first it was just a texture thing. No, it's okay. It's time. Hit the start up here. You need a calculator, so please pull out your calculator. If you use your phone, you better stay the heck off the web. Go by yourself, Chapman? Must be lonely back here.
Scared them all away.
It's lonely at the top, you know. Now you have company.
Dr. Bradovich,
Yeah,
are you gonna like email us the quiz or are we
I
gonna
just
be
did.
doing it? Oh, you just did? Okay.
yeah, check your inbox.
Okay, thank you.
bring it to put in my box or in my office, either one. Yeah, either one. Yeah. Cheers.
There's an interview with a pharmacist.
Uh-huh.
Doesn't have to be a true pharmacist or just one who is legally able to prescribe drugs away. Because I have a dentist friend, and he said he is like a prescription pad, like he knows drugs. And like,
No, I prefer it to be a pharmacist.
okay, that's fine. Oh, that's fine.
There are plenty around the Jackson area, so.
No, that's fine.
Are there any more quizzes out? One more? Okay. Very good. So the vocab sheet you can turn in to me sometime today. You can put it in my box in the natural sciences office or send it via email or yeah, whatever. It however you turn it in is fine as long as you get it to me by today. Okay, we looked last time at putting together a dosage for your drug. We took a look at some of the ways you can do that. Now let's look at some of the variables that can cause you to adjust the dose in a patient. Remember, the factors of pharmacokinetics are absorption, distribution, metabolism, and elimination. And these can vary from person to person. So absorption, we talked about some of these already, but of course, if someone has any sort of GI disease, there are diseases that affect motility. There are some diseases that increase motility. There are medications that increase motility. These can decrease absorption. There are some conditions that increase motility, drugs that increase motility as well. So, for example, patients can have so-called irritable bowel syndrome, but irritable bowel syndrome comes in 3 different types. There's a irritable bowel syndrome that's characterized by constipation. Then there is an irritable bowel syndrome characterized by diarrhea. Then there's a mixed, where you get kind of the worst of both worlds. So if someone has this condition, they have increased motility of the bowel. Drugs are going to move through the GI tract much more quickly. They won't be absorbed as efficiently. Whereas this condition, drugs will stay in the bowel longer. You may get more absorption in that case. And then with mixed, it's probably going to vary from person to person. You can't really tell. Likewise, patients may have things like Crohn's disease. And this is an inflammatory bowel syndrome. And this will scar the GI tract. Scarring means you're going to have areas that don't absorb anything. because Crohn's disease will affect the small intestine. That's going to greatly affect absorption. Now, ulcerative colitis is the second inflammatory bowel disease. That just affects the colon. However, if you have active ulcerative colitis, you've lost a lot of blood. You have less blood circulating through the bowel. Are you going to have absorption that is as efficient? No, you won't. So this will depend if the disease is active or if it's controlled. But because this does not affect the small intestine, this will have less of an effect on absorption than will Crohn's disease. And as we said before, drugs can affect the bowel too. So for example, opiates. One of the side effects of opiates is constipation. And there are lots of others that do the same thing, and so on and so forth. So absorption can be subject to diseases, drugs, also nutritional status as well. Those are all things to consider. There was a case study that was published in Annals of Family Practice. And this case study started out with probably the strangest vignette I've ever heard. And the doctor described his patient. She was a successful 27-year-old professional woman who came in and said, you know, when I walk through the staircase and I take a deep breath, I go, oh, the smell of concrete. Oh, that smells good. Man, I just really dig that smell of concrete. Now, reading that, I said, okay, he should refer to a shrink. That was my first case, but it turns out she had an undiagnosed irritable bowel syndrome disease. She was deficient in minerals. She had a condition called pica. Pica causes you to desire non-food elements. Turned out sitting at her desk, she'd chew on paper. And she wouldn't even think about it. So her Post-it notes, the edges were gone because she chewed on them. And the doctor said, well, how many of these do you chew on a day? She said, oh, 14 or 15. And so he wisely sent her for a blood test to test for minerals. And she was deficient in almost every one of them. So she had pica. And pica is not common in this country. That's why it's often missed. But this clinician was able to catch it. And it turns out she had undiagnosed irritable bowel syndrome. So he fixed that. And then all of a sudden, her appetite ballooned, and so did her weight. And then she had to get a gym membership to lose weight. And anyway, so it was an interesting story, but this shows you essentially how nutritional states can affect appetite, how that can affect absorption as well. All right. Clearance, of course, is subject to lots of different features. Since the kidneys are one of the biggest players in clearance, any sort of kidney disease can increase half-lives of certain drugs usually, or of their metabolites. Because metabolites of drugs may have activity, or they may have side effects. If you increase the half-life of those, you can increase both the activity or the side effects or whatever of the drug. Kidney function decreases as you get older. So with every year after 30, your renal function goes down about 1% every year. So older people for certain drugs will just have longer half-lives. And that's something to keep in mind. That's even if you don't have kidney disease. If kidney disease, then it's another story. We discussed volume of distribution and the effect of aging on it. What if you have a patient who is very severely underweight and you're giving them a lipophilic drug? They're not going to depot that drug. Because they're not going to depot that drug, the standard dosage for that drug might be too high. What if you have a patient who's pretty severely obese and you give them a lipophilic drug? Now they're going to depot that drug, and the amount of drug available for therapeutic effects might be smaller. You might have to dose them up. All things to consider. And half-lives. Because of the variability in our livers, both the blood flow to the liver and the enzymes in our livers, certain compounds will have different half-lives. Let's use an example that's very close to home for many of you. So my family, I'm Eastern European heritage. I come from a family of grape farmers. The fruits of the vine flowed very freely in my household. And if I went to weddings, it was pretty common for people to drink too much in my family, but they had to drink a lot before they had too much to drink. We metabolize alcohol very slowly. So my brother, when he was in high school, sowed more than a few wild oats, shall we say. And Tom used to do these drinking games with his friends. He'd always win because we metabolize alcohol slowly. Now, some of my friends, when I was a kid and I picked grapes in the fields with my friends who were largely from Mexico and Central America, they could drink half of what my family could drink, and they were affected. They metabolized alcohol very quickly. This is an inherited feature. The enzyme that metabolizes alcohol dehydrogenase, has genetic variability from person to person. So some people metabolize it quickly, some metabolize it slowly. It's the same with drugs. Some will metabolize them well, quickly, others very slowly. So the dosages are for kind of standardized, you may need to adjust. So half-lives can be affected. Also, half-lives might be affected because you don't clear the drug as well either. These are also features of not just the liver, but the kidneys, the GI tract, circulation, all those sorts of things. What will be the case if a person has liver disease of some sort? What will the half-life of drugs be in that case? If you have a diseased liver, is that diseased liver going to metabolize drugs as quickly? No. So your half-life will tend to be increased, in some cases substantially. And there are equations usually for adjusting dosages for people with hepatic diseases, other drugs you just can't give them to people with certain types of hepatic diseases. Pharmacodynamics can also vary from person to person. So, for example, if you get out of surgery, usually the nurse asks you, what's your pain level? And if you listen to that nurse, he or she will tell you stories about patients who get out of surgery and right away they say, I can't take it, I can't take it, I can't take it, give me some more. Others will lay back on the bed and say, I'm fine. Why do I need anything else? Don't give me anything. That is very individual because responses to pain are very individual and relief of pain is very individual. Same thing with drugs. We will see with, for example, blood pressure medicines, some people respond really well to them. Others respond very poorly. And you have to pile one drug on top of another. So there is a variability when it comes to sensitivity to drugs. Some people too will have physiologies that just render them insensitive to a drug. That's the way it goes. Others may have some sort of antagonism with some of the drug they're taking. Ferreting that out might be difficult, but it might very well be the case. It's hard to say. Now, some drugs are going to bind to serum proteins. Because they bind to serum proteins, they won't be available either for metabolism, for elimination, or for therapeutics for that matter. So you'll have a equilibrium between the drug that is bound by the serum protein and the free drug. It's only the free drug that will be able to participate in the therapeutic effect of the drug. So negatively charged drugs bind albumin. Positively charged drugs will bind the alpha-1 acid glycoprotein. The concentration of these proteins varies from person to person. They'll also be affected by the health of the liver. So aspirin binds to albumin. What if you have a patient who's an alcoholic, who has alcoholic liver disease? That 325 mg of aspirin that they took now is not going to bind albumin because their albumin is going to be really low because they have a liver that works very poorly. These are all things to consider. Also, there is a steroid hormone carrier in the blood. If you take a steroid hormone, it'll bind that steroid hormone carrier. So steroids in general will bind to blood-based proteins kind of as a rule. And when they do, they will tend to displace your native hormones. They might displace testosterone or estrogen or something like that. So capacity limited protein binding simply means you have a finite number of protein binding sites, drug binding sites in your bloodstream, and the dose is usually calculated to take into account all those potential sites. If you have two drugs, both of which bind to the same blood protein, those drugs will compete for binding to that protein. And one may displace the other. And we'll make reference to that as necessary. One of the big culprits of this is the anticoagulant warfarin. Warfarin's a notorious protein binder. So it is essential to obtain a maximum value from a drug concentration measurement. So if you're going to measure drug concentration in the blood, you make sure you measure it just after they've taken a dose. That's important if you're going to get some sort of measurement of the drug in the bloodstream. And if you want to do some sort of correction for the volume of distribution or for clearance, you can use body weight and then correct for volume of distribution. There are tables for that you can look up usually. And then for drugs that are excreted by the kidney, you can use creatinine clearance. Now with liver function, it's common for people to think that you could order a panel of liver function tests that will tell you how well the liver metabolizes drugs. No, liver function tests do not correlate with drug metabolism. However, when it comes to the kidney, creatinine clearance correlates very well with drug clearance. So that is one you could use for drug clearance, and there's just a standard equation that you use here. It's shown here. 160 minus the age in years divided by 22 times the creatinine that you measure, and then multiplied by weight and correction factor if your patient's female, and blah, blah, blah. And yeah, you can plug that into a Excel spreadsheet, in fact, and figure that out really quickly. And that is the straight skinny on pharmacokinetics. All right. So remember we said that pharmacokinetics involves absorption, distribution, metabolism, elimination, or clearance. Let's take metabolism. Let's camp out on that. That's what we're going to do now. So if you walk into your house, in your house, if you have carpet, that carpet is constantly releasing molecules that are volatile that you're breathing in. The paint on the wall is releasing molecules that you're breathing in. The material from your clothing, be it a coat, be it a sweater, whatever, you're breathing those molecules in. The shampoo that you use in the morning has molecules that are releasing. You're breathing those in. I'm not trying to scare you. I'm just trying to say we're exposed to lots and lots and lots of foreign chemicals every day. And turns out indoor air pollution is much worse than outdoor air pollution. That is one of the reasons why spending time outside, even in very cold weather like this, can be very good for your pulmonary health. Because the number of xenobiotics outdoors is diluted, and you're not exposed to quite as many. So these foreign substances are called xenobiotics. Xenobiotics. What does your body do with xenobiotics? Well, it excretes them. There's a problem. What if the xenobiotic is not very water soluble? Then the kidney's going to have trouble getting rid of it. So what does the body do? It will try to detoxify it. It'll also try to inactivate it. But the best strategy your body has is to make the compound more polar, more water soluble. If it makes it more water soluble, the kidneys will excrete it more efficiently. This is the nature of drug biotransformation. It is the liver, mainly the liver, taking the drug and trying to make it more water soluble. Now, does this sometimes inactivate or detoxify the drug? Yeah, sometimes it does. Does it always detoxify, inactivate the drug? No. Sometimes it actually makes the drug worse. So the goal of biotransformation is not detoxification. It's to make the drug more polar. To make the drug more polar. So because of the first pass effect, some drugs never make it into the general circulation. They go from the GI tract to the liver, and the liver chews them up right away. You never get any sort of appreciable concentration in the systemic circulation. Now there's two phases to drug metabolism, phase 1, phase 2. Phase 1, phase 2. Phase 1 reactions usually occur first. Usually. There are exceptions, but the phase 1 reactions usually occur first. Then there are phase 2 reactions. These are two separate sets of enzymes. Phase 1 are usually oxidation reactions. Usually, oxidation reactions. What is an oxidation? Very simply, oxidation means you have had an electron stolen from you. So if this is Jesse's electron, if I pinch this, as the British would say, I have oxidized Jesse. So Jessie is now oxidized. She lost her electron. Now, if I were to give her another electron, now she's reduced. She's reduced. So reduction, you gain an electron. Oxidation, you lose an electron. Phase 1 reactions are usually oxidations, or they might be reductions, but they usually have to do with giving or taking electrons, usually taking. Phase 2 reactions are catalyzed by transferases. Transferases. These transferases take charge groups and attach them to the drug or the drug metabolite. So they'll attach acetyl groups, they'll attach sulfur groups, they'll attach glycuronic acid groups, they'll attach various types of big, bulky, water-soluble groups to the metabolite or the drug itself, and that will make it more water-soluble. So, and many drugs undergo phase 1 reactions. You now have a metabolite. That metabolite may or may not have activity. Then they undergo phase 2 conjugation, and then they're excreted by the kidney. Some drugs will pass phase 1, go straight to phase 2, and then be excreted. So not all drugs go through phase 1 reactions, just phase 2 in some cases. Some drugs aren't modified at all. They just go straight through and out they go. Lithium, for example. Lithium, straight through, gets excreted as lithium. The trend will be you start as a more water-hating molecule and you become a more water-loving molecule that is more easily eliminated. That's the trend. Josh, your hand was, did you have a question?
I'm trying to figure out to ask it. So, if it has a phase 1, is it always going to have a phase 2? If you said it could skip phase.
Usually, I can think of 1 or 2 exceptions. Well, actually, I can think of 3 or 4 exceptions. So there are cases where drugs may go through phase 1 and don't go through phase 2. Those are uncommon, but they do, those cases do exist. So the phase 1s usually occur first. There are some exceptions. Here's one. So the tuberculosis drug, anti-tuberculosis drug, isoniazid, undergoes a phase 2 reaction first, acetylation. So this is catalyzed by an acetyltransferase. And then this adduct, an acetyl isoniazid, undergoes a hydrolysis as a result of phase 1 oxidation, and it makes acetylhydrazine. And acetylhydrazine can be toxic to the liver if it builds up in appreciable concentrations. So if a patient of yours is taking isoniazid, what organ are you going to check religiously? Their liver. In fact, when a patient is going to go on isoniazid, and they have to be on isoniazid for 6 months, when you're treating tuberculosis, you do a liver test first before they go on the drug, so you have a baseline. Then in the middle, you do a liver function test, and if it's fine, they stay on it. Then you do one at the end, and then after they've gotten off isoniazid, about 2 months later, 3 months later, you do another one to make sure there's no lingering liver damage. Allison? Depends how extensive the damage is. If the damage is extensive, no. If the damage is slight, yes. The liver is an organ that's very good at regenerating, but the liver doesn't remake large swaths of damage. Instead, it scars. So small bits of damage, yes, can repair. Large swaths of damage, no. So that's why you want to keep liver damage minimum, because that will repair itself. Does the liver always inactivate drugs? No, because some drugs are prodrugs. So there are plenty of examples here, but one is omeprazole, the proton pump inhibitor. Most proton pump inhibitors are prodrugs that need to be activated by the liver. Codeine is another one. Tamoxifen is another one. Blah, 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 so on and so forth. Some drugs have active metabolites. So the blood pressure medicine, losartan. Losartan is active, and then its metabolite, EXP 3174, is actually even more active. So is losartan a prodrug? No, because the actual drug is active. Its metabolite's even more active. The antidepressant, venlafaxine, is converted into desvenlafaxine. Desvenlafaxine also has activity, even more activity than venlafaxine. So venlafaxine also, trade name is Effector. Effector is the name of venlafaxine. That drug is given to people with PTSD. That's the drug of choice for vets with PTSD. That also goes through and gets made into an active metabolite. And then some make metabolites that are potentially deleterious. Isoniazid being one, acetaminophen's another, morphine, so on and so forth. Okay, let me pause, see if there are any questions. The main players in phase 1 are the cytochrome P450s. Cytochrome P450s. This is a family of enzymes. They are closely related to each other. So just like in a family, you might have George and Bill and Sue and Francis and Edna and William and Rachel and whatever. You have different members of the cytochrome P450 family. These enzymes contain an iron heme group, just like the kind you have in hemoglobin. They are capable of a very wide variety of reactions, and they are very, the term used in biochemistry is promiscuous. Now, why do they say promiscuous? They're promiscuous because they can accommodate many different substrates. So that's how these drugs are able to metabolize lots of different drugs, because these enzymes aren't picky about their substrates. The reaction they carry out is a multi-step reaction, and it requires this cofactor NADPH. This is derived from dietary niacin and then molecular oxygen. Let's take a look at how these enzymes do their job. So they are found predominantly in liver. They're also found in the small intestine. Others are found in the kidney and in other peripheral organs. There's some of these in, for example, ovaries. There's some in the brain. But for our purposes, liver, big hitter, small intestines, leadoff hitter. So the big gun here is the liver, It uses molecular oxygen to oxidize the substrate. Then it uses the reducing equivalents from NADPH to essentially take the oxidation products and give them electrons and make them more stable, so that you don't produce reactive oxygen species or something like that. And here is the set of reactions they tend to run. This is very generic, but you have your substrate, which is RH. Here's your cytochrome P450, and it will bind the drug. The iron is the moiety that will bind the drug. Bound to the iron, it experiences the reducing equivalent, and then that converts the iron from an iron 3 plus 3 to iron plus 2, from iron plus 3 to iron plus 2. Then it gets hit with molecular oxygen. Now you have this complex here, complex here. Now the oxygen will take up electrons from the iron. It will then form an adduct with the iron. That oxygen gets transferred to the drug, making a hydroxylated version of the drug, and that is more soluble than this. So you completed your mission. You've now made something that's much more water soluble. This is a structure of one of these cytochrome P450s. Here is the iron in the center. There's the drug that's bound to it. This drug is camphor. So if you've ever used Vicks Vapor Rub, that smell, that's camphor. If you've ever used some cough syrups, some cough drops will have camphor in them. So camphor is bound to the iron. There is a path for the drug that goes through here. You might see a little tunnel here. That tunnel is a different size. In the different cytochrome P450 family members, they can bind different drugs, and that's essentially how the drug will bind to the iron via this pathway here. Now this picture shows you that the enzyme is bound to a membrane. In fact, these enzymes are found in the smooth endoplasmic reticulum of the liver cells. The smooth endoplasmic reticulum of liver cells. So they're associated with membranes, and a piece of the protein sticks into the membrane and anchors it to the membrane. Now, some fun facts about cytochrome P450s. Number one, several of them are inducible. Several of them are inducible. Not all of them, but several of them are. 2, they're subject to extensive genetic polymorphisms. So depending upon your heritage, you will inherit cytochrome P450s with different capabilities. And you will have a capability to process certain drugs, and that capability may be limited when it comes to other drugs. So this genetic polymorphism means your enzymes are uniquely yours. 3, they're subject to inhibition by some drugs. They're subject to inhibition by some drugs. Cytochrome P450 inducibility and inhibition are going to be the basis of drug-drug interactions in many cases. 4, there's over 50 isozymes of cytochrome P450s. However, there are really only about 6 that are important for drug metabolism because they're the main 6 ones. They are cytochrome P450 3A4, that's the big one. Majority of drugs are metabolized by 3A4. Then there's cytochrome P452D6. Cytochrome P452C9. Cytochrome P452C19, 2C19, and cytochrome P450 1A2. Those are the main cytochrome P450s. Those are the ones you'll need to be familiar with when it comes to drug-drug interactions, because those are the ones that metabolize easily 98% of all drugs. All right, we are now going to look at some of the reactions catalyzed by these enzymes. What I want you to see is this. How do you get something that is very water non-soluble and make it more water soluble? That's what I want you to see. Do I want you to know the details of these reactions? No, I just want you to see what they can do, because what they can do is pretty remarkable. So if you have something like this, a benzene ring, that's very poorly soluble in water. Lots of drugs have benzene rings. These enzymes can stick a hydroxyl group on it, and now this becomes much more water soluble. Much more water soluble. So they can stick more water-loving groups onto benzene rings. They can also stick these hydroxyl groups onto these aliphatic rings. They can stick them on the end, they can stick them in the middle, whatever. There's lots of drugs that they do that too. And these are examples again, not very water soluble, almost a gasoline-like molecule. Boom, now you make it much more water soluble. What do you do with something like this? You can make an epoxide. And epoxides are much more soluble than something like this that is an alkene. Take the alkene, you make the epoxide again. You're making it more water soluble. And we're out of time. We'll pick this up on Monday. We'll run through these, then we'll get into drug-drug interactions. Okay, it's right on the vial.